Hey, future health heroes! Get the study guides and tips you need to ace your nursing exams. Follow us for more.
All right, today we are doing a clinical deep dive on folic acid. Now, I know it seems like a simple, common supplement, right? But here's the thing. Using it the wrong way can lead to some really devastating, and I mean irreversible harm. So we're going to cover its uses, how to administer it safely, and the single most important warning you absolutely need to know to protect your clients. So let's kick things off with a little clinical puzzle. What's the one single vitamin that links together megaloblastic anemia, pregnancy, and even alcohol use disorder? Well, you guessed it, it's folic acid. And trust me, understanding this connection is absolutely crucial for using it safely and effectively. Here's our game plan for this explainer. We'll start with the why, what it actually treats. Then we'll get into the how, the right way to administer and monitor it. After that, we'll look at the potential risks, and then we're going to dedicate a whole section to a super critical B12 warning before we wrap up with what you need to tell your clients. Okay, first up, the why. Why are we even prescribing folic acid? Well, it's for a few very specific and very important reasons. Its main job, really, is to tackle something called megaloblastic anemia. And this isn't your typical anemia. It's a condition where the red blood cells that your body does manage to make are way too big, and frankly, they're not very effective. Think of folic acid as the key ingredient the body needs to build these cells the right way. So when you boil it down, we've got three main therapeutic uses. First, treating that megaloblastic anemia we just talked about. Second, it's used for correcting a folate deficiency, which you see pretty often in clients with alcohol use disorder. And third, and this is probably its most famous role, is preventing those devastating neural tube defects in a developing fetus. Okay, so we've covered the why. Now let's dive into the how, because proper administration and careful monitoring, well, that's what separates safe, effective practice from a really risky situation. Now, this protocol looks pretty straightforward, but you cannot skip a single step. The very first thing you do before anything else is check those vitamin B12 levels. We'll get into exactly why in just a minute. After you've done that, you'll get your baseline labs, your hemoglobin and hematocrit, your HGB and HCT. Then you can administer the folic acid, and of course, you'll monitor those same labs to see if things are improving. So you start the therapy. How long until you see something happen? Well, you should expect to see that hematocrit, or HCT, start to tick up within about 2 weeks. That's a really key early sign that the treatment is working. Of course, every medication has potential risks, and folic acid is no different. Let's walk through the what-ifs, the adverse reactions you need to be watching out for. The reactions really range from the pretty minor, like urine turning a brighter yellow, which is harmless, to much, much more serious. For instance, long-term use has been linked with an increased risk for certain cancers, but the most immediate, clear, and present danger in the clinic is its ability to mask a vitamin B12 deficiency. And that brings us to the single most important warning. This is a direct quote from clinical guidelines, and it says, folic acid therapy can mask the manifestations of B12 deficiency. This isn't some rare one-in-a-million side effect. It is a fundamental risk of the therapy that can lead to severe, permanent harm if you miss it. Honestly, this point is so incredibly important to using folic acid safely that it absolutely deserves its own section. So let's take a deeper dive into this critical B12 warning. Here's the trap. This is how it happens. You give a patient folic acid, and hey, their blood work looks great. The HGB and HCT improve, the anemia gets better. But, and this is a huge but, if the true underlying cause was a B12 deficiency, you've only fixed the numbers on a lab report. You haven't fixed the root problem. Under the surface, that neurological damage is still happening, and it can become permanent. So what's the bottom line here? The big takeaway? It's this. You have to confirm that there isn't a B12 deficiency before you start. And if your client does have a B12 deficiency, they absolutely must get adequate doses of cyanocobalamin, that's vitamin B12, right alongside the folic acid. That's the only way to prevent that irreversible neurological damage. All right, finally, let's shift gears and talk about the patient. What do they need to know to be safe and successful? Because clear instructions are everything. You want to keep the instructions simple and actionable. First, encourage them to eat a diet rich in natural folate. We're talking leafy greens, beans, things like that. The pill is a supplement, not a replacement for good nutrition. And second, tell them to call you immediately if they develop any kind of rash, because that could be a sign of a hypersensitivity reaction. So let's just quickly bring it all home. What's the one thing you always check before starting therapy? Vitamin B12. And what are you looking for as you monitor? Improvement in those hematologic markers. Getting that sequence right is non-negotiable. And that really leaves us with a final thought, doesn't it? The whole story of folic acid is such a powerful reminder of a core challenge in medicine. Are we just treating the symptom, or are we digging deep to find and treat the root cause? It's a question we should be asking with every single patient, every single day. Thanks for joining me.